Hello, everybody. Welcome back to the Capability Corner, the podcast where we explore what's happening in healthcare, workforce development, and capability building. I'm Zoe Yule, Head of Learning at Capability.AusMed, and today we've got a bit of a bonus episode for you. So do not fret, Karen, Michelle, and I will be back to our regular episodes soon. But today we're going to take a bit of a deep dive into a topic that truly has really shaped my own clinical practice. And I do really think it is one of the most important conversations that we all need to be having in healthcare today. If you haven't already guessed it, we are talking about trauma-informed care. Now, I'll make a strong case in this episode, but I do want to explain that it is not just a topic for our clinical folks working in mental health or addictions. This topic really is a foundational principle for how we build our teams, how we create a healthy culture, how we support our people. And it really is about creating that psychological safety that we know is essential for anyone, for all of us to learn, to grow, to perform at our best. It is one of the core capabilities that underpins everything that we do. There is no one that I would actually rather explore this topic with than my dear friend and a true expert who I've worked with and admired for nearly 15 years, and that is Dr. Clarke. Earlier this year, I had a great pleasure of catching up with Karen Ann while she was down in the AusMed office speaking at an event for us. And I think she's the perfect person to share this topic with us. Her career is this blend of clinical practice and pedagogy. She started her career as a registered mental health nurse and now leads the development of some very large undergraduate health and nursing programs in Queensland. So in our conversation, Karen Ann explains the research that underpins the entire trauma-informed approach and really helps us all understand why for clinicians, for educators, and those supporting workforce development across healthcare, why this is such a critical topic. So let's get started. Hello and welcome to you, Dr. Karen Ann Clarke.
Hello, Zoe. It's been a long time and I'm so excited to be here. Thank you for inviting me.
Thank you. Thank you for joining us. I have had the privilege of knowing you 10, 15 years?
Almost 15, I think.
Yeah.
Almost 15.
Many listeners might also recognise the name and the voice. You, for many, many years, presented for us at AusMed. Tell us about your background though. Who are you? What do you do? What do you love?
Professionally, I am a registered nurse. I am a qualified mental health nurse, and that's where I spent the majority of my career, was in the mental health space. So I was thinking about this the other day and thinking about when was it that I very first started teaching? And I realised that I started teaching when I moved to Melbourne, way back in the late 80s. Back then it was called postgraduate psychiatric nursing. So it was, the 15-month course that you do after you've graduated from your 3-year hospital-based nursing. And I remember being approached by some psychiatric nursing students who were doing the 3-year course. And they were struggling with basic anatomy and physiology, just couldn't get their heads around it, and said, would you do a bit of a study group with us? So they came to my home one Tuesday night and there were 4 of them. And the following week, there were 8 of them. And the week after that, I realised that my living room was way too small to be putting all of these students and just doing fundamental anatomy and physiology. So I got permission to use a boardroom at the hospital that we were all, this was back in the days of Footscray Psychiatric Hospital. So for people who are local, they'll remember that. It was in the car park of Western General Hospital. And within a couple of weeks, I had an entire classroom in this boardroom. And I would love to say that they all graduated from, they ended up doing their state finals and did incredibly well. And I realised that that was where the passion of educating students first really, took hold. My mother was a nurse, my dad was a teacher, so it was inevitable that at some point I was going to hit the nexus of the two.
In your DNA?
Yeah, it was in my genes. So I got to probably about 2007 and I was had been working clinically in the mental health space for a very long time, and was approached by an acquaintance at the time, a professional acquaintance, who asked if I would like to teach casually and teach the mental health course to a small group of nurses. The nursing program at the University of the Sunshine Coast had just started, and there were probably about 100 odd students in the entire cohort. So I very anxiously and very nervously turned up for my very first class thinking, this is a different kettle of fish. This is very different. This is now the big guns. This is higher education. Can't just wing this one. You have to be organised for this. And I would like to say I kind of really didn't have much of an idea, but I just went in with passion and with an authentic desire to teach all things related to care of people with mental illness, something I was really passionate about. And the rest is kind of history. I hung around. I hung around and realised that I was working 2 jobs. I was still working clinically as well as teaching a couple of days a week. And they were the days when I used to wake up. I used to say I used to wake up with a smile on my face because teaching students was very exciting. How do I do this permanently? How do I make a career pathway in academia? Because it was something I was very, very passionate about. To get a foot in the door in academia means you have to have at least a master's and you need to be working towards your PhD. And so then I did my Masters of Mental Health Nursing after that. So it was just a continuous leap. For me, it was just an expectation that a PhD was just a natural progression. I didn't blink an eye at it. I think about that and sort of laugh silently because it is a big deal. It's a 6-year big deal.
I remember the day at the time that you finished it. And, we're all counting down.
That was pretty exciting.
Chat.
That was pretty exciting.
How are you going?
I'm submitted. So currently I work as the program coordinator for 2 undergraduate nursing programs based at the University of the Sunshine Coast. So we have our undergraduate, our Bachelor of Nursing Science program, and then we have a graduate entry equivalent of the same program.
And memory of the light bulb moments that went off in my career clinically when I was working with you at AusMed. So as I mentioned, we had the absolute privilege. You were still very busy back then, and we made your diary a lot busier. You would go around and you'd present in places like Hervey Bay. We'd do remember going up to the Hervey Bay Nurses Conference and beating burnout in Noosa and sending you to
I remember every one of
the
those.
2-day schizophrenia seminar and I had this amazing role in this non-clinical education role at AusMed where I would work with you, the content expert, to design and develop the program. And as I'm sure our listeners can hear, we would start talking and we'd get on the phone and we'd say, hi, Karen Ann, it's Zoe at AusMed. I'm just ringing up to see if you'd be interested and available to pop down to Melbourne in a couple of weeks' time. And we'd have these conversations, but I'll get serious for a moment because one of the things that I learned from you, I'm going to say it was probably 10 years ago, but correct my timing if I'm a bit off. But at least 10 years ago, I was doing a bit in ICU and a bit in AusMed. And it was a conversation I remember having with you. It was a real change in my clinical practice. And I say openly, there's been 2. There's probably been thousands, but there's been 2 really big changes in my practice from graduating, my bachelor, and doing a postgrad and all that, master's, whatnot, and working. And the first was oxygen in chest pain. When I was an undergrad student, we were taught that, someone with chest pain, cardiac related, you whack on that oxygen, you turn it up full ball, and they need that 10, 12, whatever it was, liters of oxygen. And then by the time I did my postgrad, no, evidence changed. We've got oxygen toxicity, and we no longer do that. That was the first big change in my clinical practice from, undergrad to clinician. And the second was trauma-informed care. And that came from a conversation with you. And also just want to acknowledge Dr. Jill Beattie, who did a lot of work for AusMed at the time. And hello, Jill, give me a call if you're listening from South Australia. Jill did a lot of work. And then as did a lot of other mental health clinicians and educators, Jeff Ahern. But the conversation with you around this topic was life-changing for me. It taught me so much, and I want to let you explain it. but I just want to acknowledge the impact that you had on my career. And I know that you've had that same impact. And what I hope our listeners can get out of that, whether you're in a clinical practice role, academia like Karen Ann, education like myself, or you're a CEO, whoever you are, there's something that everyone can take out of this concept of a trauma-informed approach to care. So over to you, my love. Enlighten us. Unpack this massive topic in as simple a way as you possibly can, to share, what this actually means.
It's really important that we understand what trauma-informed care is and how very, very small acts of trauma-informed care can actually have a massive impact on the experience of people who are receiving care from us. And so, the Diagnostic and Statistical Manual, which is our Bible of mental illness, talks about trauma as being a terrible event that happens to somebody. And it acknowledges that trauma is a very subjective experience, that many of us will experience the same thing but respond very, very differently. And it has a range of responses that we will experience and that will be expressed. But when we're talking about trauma-informed care, I think we need to take a step back and actually acknowledge some really fundamental research that occurred in that space that really opened up our understanding of what trauma-informed care was. And back in the late 80s, early 90s, there was a pivotal piece of research by Felitti and his colleagues that was called the Adverse Childhood Experiences Study, the ACEs. And people may have heard of the ACEs because we hear about them so frequently now. But essentially, it's a really fascinating sort of story where it came from. But just in a nutshell, really quickly, it came from some research that stemmed from Kaiser Permanente, who are a really big health maintenance organisation in the United States. Kaiser Permanente put some money together to the CDC, the Centre for Disease Control organisation in the States, and said, we'd be really interested to find out if there are other things that happen to people in the early childhood years and how it affects their health as grown-ups. Did a massive big study. It was a big survey, 17,500 American adults, got them to identify a whole range of what they termed the adverse childhood experiences. And there were 10 of these that they were looking for. And they asked people, had you ever experienced any childhood sexual abuse, physical abuse, emotional abuse? Had you experienced any physical or emotional neglect? Did you come from a highly dysfunctional family? So, for instance, did you have parents with mental illness or parents with drug and alcohol abuse? Did you come from a divorced family? Did you live in a family where you had a parent who was incarcerated? Most importantly, did you live in a family where you saw your mother be beaten? Those were the terms that were used. Did you see your mother being beaten? So they were looking for domestic violence. Then at the same time, they asked people to fill out a survey about their current health, and they basically went top-to-toe assessment, and they were looking for a whole range of different conditions, anything from respiratory, neurologic, cardiovascular, diabetes, obesity, smoking states, that sort of stuff. The research was astounding at the time because it acknowledged that these adverse childhood events, these ACEs, were incredibly common. In fact, 1 in 4 adults had at least one ACE. And if you think about, the rates of family breakdown, hitting one ACE through divorce is pretty simple. But what they found was that there were incredibly high numbers of ACEs. People were experiencing complex number of ACEs. What they then did was they correlated it to the health conditions. It was actually quite devastating because it was scary research, scary findings, because they found that the higher the number of ACEs that a person experienced, the worse their health outcomes. People were experiencing incredibly high rates of cardiovascular disease, respiratory conditions, cancers, mental illness, drug and alcohol abuse. And in fact, if you had between 4 and 5 ACEs, which are quite easy to grab hold of, because abuse doesn't happen in isolation. you cannot experience physical abuse without the emotional abuse. Yeah. Sexual abuse contains all of those, together. What we know about life now is that multiple ACEs are experienced at one time. So that research at the time that was published in the early 2000s actually demonstrated a 12.5 higher risk of somebody dying by suicide if they had 4 to 5 ACEs in their background. And this is in the first 8 years of life. So it's really important to understand the nature of trauma. In the original research, each of those ACEs represented one discrete moment of stress. Yet when you take across the lifespan of that research, the cumulative effect of the ACEs really demonstrates a cumulative stress response. And what the research found was that there is a dose-dependent response of stress on the developing brains of young children who are experiencing these. So, for instance, somebody who is experiencing, a childhood that is full of of violence and neglect and abuse. This is a child whose brain is it's their brain and their body is constantly bathed in stress hormones. They are literally trying to survive. So this is why it became really important as we moved on in the research, and there is just such a huge body of research now that investigates the health outcomes related to. This was groundbreaking research, Zoe. It's gone such a long way now, and the word ACEs, the word trauma, it's part of the vernacular. It's part of everyday language.
Every state, every organisation.
Absolutely. But what is still fundamental is that we are caring for adults with chronic health conditions in their mid-years, and in fact, their early adult mid-years, where the origins of those health conditions started back in childhood. And it's been very clearly demonstrated the impact on the brain of young developing children and how that relates to how they function as adults in the world. But the one thing I want to remind us both at this moment is that we need to stop looking at individuals in our care and wondering in our minds and saying, what's wrong with you? And we need to
actually saying it
and saying it.
Which unfortunately we hear as well.
Exactly. And we need to change that question from what's wrong with you to what happened to you. What has happened to you? The minute that you utter those words, or the minute I utter those words, I can feel a real softening of my compassion towards somebody. Instead of what's wrong with you, it's what happened. Even your language changes, even the pitch of your voice changes. So to actually say to somebody in a very quiet moment, I have a feeling there's more to this story. What's happened to you, is inviting somebody to be really vulnerable with you. And to do that requires a real sense of safety. But you're actually opening up a safe space by talking to people in that way, by saying, tell me your story. It's okay. So safety is a component, is a central component of trauma-informed care. A trauma-informed approach recognises that people who are providing care are often traumatised individuals themselves. And so we end up with healthcare systems where hurt people are actually unintentionally hurting people. We respond with frustration, and we respond in a manner that actually is deeply rooted in our own DNA, in our own upbringing, that has very little to do with the people receiving care. So they come in traumatized, we come to work traumatized, and it's just a recipe for disaster. So having a trauma-informed understanding of healthcare, of the way that our hospital systems work, and more importantly, the way that we can provide care to others fundamentally shifts that. Now, to be fully trauma-informed, an organisation needs to be approaching this from the same lens, from the CEO at the top all the way down, everybody from our cleaning staff to our frontline nursing staff, to people in CSSD and people in pharmacy and people in the gift store. We all need to have a trauma-informed approach. We need to be treating people in exactly the same way. recognizing the prevalence of trauma. So actually understanding that the majority of the people in your care will have trauma backgrounds of some sort. Having an understanding of the way that trauma affects people, appreciating the impact of it. But the third one, as the most important one, is a deep, abiding commitment to behaving professionally and personally, and by providing care that does not re-traumatize. Now, that can be really tricky because you go, well, how do I know? Like, where do I even start with that?
We've got to look at the environment. You've got to look at policies. This concept of a trauma-informed approach, which we're doing our best to squeeze into this short episode, it honestly is the glue that holds so many things together, doesn't it? If you think about it from a clinical practice or a workplace design, a cultural perspective, understanding this is phenomenal. So if this is the first time that you've heard in depth about this concept, make this the start of your learning journey. I guess, what I wanted to just touch on was that this is what we started doing when we were running conferences and seminars.
Yeah.
We heard...
This was a decade ago.
And if you attended one of our events, you might have remembered you'd have general wound, diabetes, medicines, and then we'd plonk trauma-informed care. And then you'd be at an isomethamphetamine conference. Remember doing all of those?
Yeah.
And we'd put a trauma, because we haven't even talked about addiction and this trauma-informed approach to addiction and mental health conditions. And then it'd show up in obesity. We do a conference on obesity and understanding that.
Well, there's such a direct link. There's such a direct link, Zoe, isn't there? Because, the thing about trauma is that people just look to self-soothe. And they look to self-soothe with coping strategies that lead to poor health outcomes. So the minute that you make that link and go, hang on a minute, people are not overweight just because they've been eating too many Tim Tams.
Why can't you just
That's right.
insert treatment intervention?
Or move more, eat less. And say, hang on a minute,
what's happened?
Yeah, what's happened and what are you doing now to self-soothe the pain? And it's about emotional pain. Yeah. So once you make that fundamental shift, the people in your care and often some of the challenging behaviours that you see in your patients suddenly make sense.
It makes sense.
They make
love
sense.
It. Absolutely. The reason why we're sitting face to face, we've had so many of these conversations on the phone, and we're both always driving, right?
Yeah.
And you hit your 10 minutes in and you'd hit your point and it cut out, and I know, okay, you're at the bottom of the hill and you call me back.
You knew where I was, whether my reception dropped out or not.
We've had a lot of these conversations over the phone, but why we're actually here face to face, which I'm still literally pinching myself that you're here, is because when I called you last year, I said, don't worry, I'm not ringing you up to send you off to Melbourne, Sydney, wherever we're going. But we want to run an event down in the AusMed office, and we want to look at the support for nurses that are experiencing a transition to practice. So you novice nurses, early career nurses doing graduate year. Are you interested in coming down to speak? And said, have you ever thought, Zoe, that we need to think about this through a trauma-informed approach? There's a lot happening here for students. So I confess I hadn't put these two concepts in, and that's what you're down here today to talk about. So given what we've heard about a trauma-informed approach, why is that so critical when we're educating, from either an academic sense, when we're often working with, challenging students or, students that are having a lot of difficulty out on placement or submitting assignments, or if we're having a lot of challenges as preceptors in the workplace? Why is it that this concept of a trauma-informed approach is so critical to education?
I am so glad you asked that question, because for me, it has just been a natural linkage between the work that I did initially and where we're sitting now. But the student challenges have changed over the years, and I know that that we were blaming COVID for a lot of that shift, but we can't blame COVID forever. COVID's long gone. But the challenges are still remaining. So it's really got me thinking about what's happening, because I'm hearing from our industry partners about the fact that students are demonstrating behaviours on placement that are not conducive to learning or are not conducive to professionalism. You know, they're argumentative, they're quite combative at times. They find it very difficult to listen to feedback. Now, this is not everybody, so I can't generalise, but when we do have, you know, air quotes here, you know, problematic students, and I need to be, you know, I'm really a big person on the power of language, as you know, Zoe. And so I often hear from clinical partners, you know, how can I manage my, you know, my underperforming students? And I'm like, well, let's think about this. Is the shift from what's wrong with you to what's happening with you. Let's shift the dial and say, rather than say, how do I manage this underperforming student? How do I support this learner?
Listeners, just to summarize, just that reframing of what the problem is, from how can I, you know, improve the performance of this student, to how can I support this student or the performance of this student, but let's say holistically, how can I support this student? That is trauma-informed care.
That's a trauma-informed
approach in action.
Absolutely.
So, one, language.
It's a small act that has massive difference.
That is your micro change that has a macro or a big impact, is reframing how we actually define or think about that problem.
Yep. But it comes back to safety. So if we go back to what we know is happening in the brain, in that emotional regulation and fundamental trust, because that is brain activity. That trust is developed through consistency, through a consistent, you know, a consistent outcome to a stimulus.
I think that's the actual definition, isn't it? Trust is that it's not the trust in the person. It's actually the trust that the repeated behaviour gets the same outcome.
That's exactly right.
Each time.
There is a consistent outcome each and every time. So whether it's good or bad, there is trust that something will happen. But when we are talking about fundamental emotional trust, let me just be really clear, and this is probably point number 2, Zoe. Point number 1 is the change in language. Point number 2 is that learning can only ever happen in an environment of trust, of positive emotional trust. So we end up with students who might be in their, you know, late teens, early 20s, or even all the way into their 30s, you know, and above, who have not developed a sense of trust with authority figures. And when I mean authority figures, I mean any other adult who wields a sense of some higher order or some higher control. So that's your preceptor. They look to the preceptor as being the adult. Now, unfortunately, some students may approach their clinical learning through that lens of, I'm going to be criticised, I'm going to be told that I'm no good, I'm a failure, I'm awful. They have little confidence in themselves. They already approach their learning through a traumatised lens. So what happens then is we end up with a situation where we've got a preceptor or a buddy who is trying their very best and wondering why the relationship seems to be failing, or why the student doesn't seem to be responding or seem to be learning, or doesn't. And this, I hear this so frequently, Zoe. They just can't take feedback. Yeah, they can't take feedback at all.
Yeah.
It's not that they can't take feedback. It's that they are hypersensitive to criticism.
And you know what happens at the other end? I hear educators, teams of education leaders, not just directors of clinical education, doing a needs assessment, thinking about what topics we need to put into a conference or a seminar for educators. And guess what it is? How to give and receive feedback. But what should we really be talking about?
Yeah,
is a trauma-informed approach.
Is understanding what's happening or why feedback is difficult to process. So don't forget, the lens of, you know, I'm a failure because I've always been told I'm a failure is already heightened. But it is not our job to judge who should and who should not be a nurse. It is our job to educate we are educators. Yeah, if we're in this space, and when you're in that clinical space, half of your job is to be an educator. It's not our job to say you should or you should not be a nurse. And I think that's a trauma-informed approach as well, is acknowledging that every single person, every single student, every single grad is doing the very best with what they have.
Absolutely.
What ends up happening at the end is not, we have no control over that. Our control is in that moment, but how to support a learner in that moment with where they're at and what they need. In addition, that can be really tricky because you're also talking about, if you are a preceptor, you are walking a very tight rope between the needs of your student and the needs of your patient.
Organisation.
Yeah.
Of course, yeah.
So that can be a bit challenging, but it's also about having the wisdom and the discernment to actually acknowledge, how much space can I give this student at the moment? Maybe, am I able to take the student aside and actually ask, what's going on? What's happened? How can I help? How can I help you to learn? So instead of this, how do I manage this underperforming student? How do I help support them with what they need right now?
Beautiful. We could keep going and going and going, as our listeners, I'm sure, can hear. What I want to end with is a big thank you to you, Dr. Karen-Ann Clarke. It's been a real pleasure to sit face to face in front of you again and have this conversation. You've got the final voice, Karen-Ann. Do you want to rattle off a couple of just names of resources or key pieces of research? You've got the ACEs study. Google that.
Yep.
What else can we share with listeners in closing to help further their learning?
So there's a couple of different websites that people can explore if they want to understand the nature of trauma, how to respond to trauma. So if you look for the Phoenix Center for trauma-informed studies, so that's a really good one. So that one's based down here in Victoria.
And I think OSMED's actually a content partner with Phoenix
good
Institute.
is that?
So if you're on, you can have a look for those links from the OSMED resource, from the OSMED library. You should be able to click on those. So they're fabulous.
Australia's done a huge amount of work into the understanding of trauma, and in fact have been recognised as a front runner in the whole space. The Blue Knot Foundation have developed this term complex trauma and are trying so very hard to get the Diagnostic and Statistical Manual to recognise complex trauma as being not just a PTSD style diagnosis, but in fact it is the cumulative effects of multiple traumas in a child's life. Now, interestingly, the ICD have acknowledged and have adopted the term complex trauma in their diagnostic listing, but the DSM-5 are holding off, and I'm not terribly sure why, but they are. That's a conversation for another day, but they have some fantastic clinical practice guidelines. So if you are, anybody who's involved in the mental health space or who's involved in working with people who have complex levels of trauma in their backgrounds, and this is a fantastic resource. They've got a beautiful, it's probably about 100-page document actually that literally walks you through all of the really important key points of working with somebody who has complex trauma, and that's really pitched at a relational level. So how to actually manage those relationships and using those trauma-informed approaches.
I've had some more light bulb moments. I hope you've been able to take one or two key things away. Thank you to our very special guest, Dr. Karen-Ann Clarke, for joining us today.
Thank you, Zoe, as always.
Oh my gosh, how good was that? I really hope you took away as many light bulb moments from our conversation as I did. A huge thank you once again to Karen-Ann for her time today and incredible insights. We'd love to hear from you if you've got thoughts on today's episode. If there's a burning capability question or topic you have in mind, let us know and we will tackle it. And we will be doing a couple more bonus episodes like this from time to time. So really encourage your feedback. It helps us shape what's next. The best way to reach us is via email, podcast@osmed.com.au. If you are one of those people that email me marketing things about podcasts, I'm not interested. I'm getting a few of those, unfortunately. But anyone that's not doing that, please send us your feedback. We truly would love to hear from it. And it is really nice. We're getting a few partners, a few customers in their emails to us say, oh, by the way, I love the podcast. So keep them coming. They do they do really, really encourage us and make it all worthwhile. But we love doing it anyway. And as always, for more insights, updates between episodes, make sure you follow us on LinkedIn or subscribe to the AusMed Toolbox. We'll see you next time.